All right, welcome everybody to our very special webinar today. This webinar is brought to you by the Selective Mutism Association and was made possible thanks to a generous grant from the Gordon and Marilyn Macklin Foundation. We're very grateful for that. The webinar is being recorded and will be available on the SMA YouTube channel within 24 to 48 hours, and a link to the recording will be sent to everybody who registered. We'll send that out early next week. As Dr. McCabe goes on with her presentation, feel free, and we encourage you to put questions or comments in the question box. I'll be curating those, and we've saved a minimum of 15, hopefully closer to 20 minutes at the end for an active Q&A. And also want to mention that the slides will not be immediately available for download, so take good notes. And it's my pleasure to welcome Dr. Kristen McCabe, who I've known for a good number of years. We are friends and colleagues in the PCIT community, that's Parent-Child Interaction Therapy. And I've had the pleasure of hearing this presentation twice, and I'm looking forward to the third time because I know my neurons are always firing and I'm thinking of new ways to apply what you've talked about, and the work is developing. So for those of you who are in the selective mutism community, you may be wondering, why do we have somebody involved with parent-child interaction therapy? And the answer is that her work has focused, this part of her work, on working with culturally diverse families and taking existing powerful treatments and making sure that they are as personalized as possible to the experiences of folks from other cultures. And frankly, as we know, PCIT and many of the other treatments we have are largely based on white families with white clinicians, and we are coming of age, fortunately, to take into account racial diversity and cultural diversity much more. So without any further ado, I will turn it over to Dr. McCabe. She's on faculty at San Diego University, having gotten her doctoral degree at Wayne State. And Kristen, thanks so much for sharing your time and expertise, and I will turn it over to you.
All right, thank you so much, Steve. Let's get myself going. Okay, all right, so what I'm going to be talking about today is actually a program of research that has been focused on making evidence-based treatments, as Dr. Kurtz referred to, more accessible, more culturally sensitive, and more effective for ethnic minority families. And I've been working in this area for over 20 years now. I want to talk about sort of the roots of that research and also kind of what we're doing right now. Okay. And I also want to thank the Gordon and Marilyn Macklin Foundation for supporting this webinar, and also to do my disclosures, which the main one is just that this research has been funded by a National Institute of Mental Health grant. Okay, so we know that the families that we're seeing in psychotherapy are diverse. In the United States is over 50% ethnic minority at this point, especially in many states. And so most of us as clinicians are working every day across cultures. We're working with people who are from a different ethnic background than our own. And so it doesn't really matter what ethnic background you're from. I mean, if you're African American, if you're Asian American, if you're Latinx, if you're European American, we're all working across cultures. But we do know, as Dr. Kurz pointed out, that PCIT was developed at a time and a place when America was not as diverse, and that diversity may not have been taken into consideration in the design of our programs to the extent that we are seeing the need for today. And sort of the good news about all that is that behavioral parent training in general, of which parent-child interaction therapy is a member intervention, is very robust. And we have a wide range of studies demonstrating that PCIT works with ethnic minority families and then also works well in international settings. So in Asia, in Europe, in Middle East, there are studies demonstrating that PCIT is actually very effective. And we actually see that the effect sizes are not very different for behavioral parent training when they're taken to international settings than they are when we see in the United States. So we should have confidence that the interventions that we're offering are effective and potentially applicable to a wide range of families. So that's great, but if that is the case, then we might wonder, why is it necessary for us to do any kind of cultural modification? Should we not just deliver these high quality evidence-based treatments to everybody who walks through our door? But there is quite a bit of evidence that suggests that that's really not enough, and that there are many ways in which ethnic minority families are actually not benefiting to the same extent that majority group families are. And so the research really indicates that just get from the get-go, ethnic minority families are less likely to enroll in programs like parent-child interaction therapy specifically, and behavioral parent training more generally. That once they do enroll, the ethnic minority families are more likely to drop out of treatment prematurely and not get, the effective dose that they need to improve their child's symptoms. That once they're in behavioral parent training, they may participate less actively, show less symptom improvement, and also take a longer time to show treatment response, meaning that the length of treatment is longer in order to get the same effect. And so those are all reasons that suggest that there's something that we need to be attending to about the way these interventions fit and work for ethnic minority families. I'm also trying during this presentation to kind of attend to how this could translate to other interventions. And I would like to point out here that although I've really tailored this discussion to behavioral parent training, this is true for a lot of interventions. So it's not just for behavioral parent training that we see lower enrollment, more treatment dropout, less active participation. This really seems to be the case across a wide variety of different types of psychotherapies. So one of the solutions that has been proposed and that I have been actively involved in is the idea that maybe what we should be doing is actually culturally modifying the interventions that we have developed that are effective. So instead of kind of, knowing that they're effective and not wanting to throw the baby out with the bathwater, it makes sense that maybe we could take the foundations of these approaches that are probably invariant across cultures. Behavioral principles probably don't vary very much across cultures, as we know they don't even vary much across the species. And so maybe what we need to do is actually come up to keep this as a basis and work on culturally modifying those programs so that they fit better for ethnic minority families. And there's been many investigators that have contributed to this work, but what my contribution was to develop a program called GANA, or Guiando Niños Activos, which is a version of parent-child interaction therapy that was adapted to fit better with Mexican American culture. And basically what we did is we looked at the literature about families' attitudes towards treatment. We did lots of qualitative work, and we consulted experts to get families' perspectives and experts' perspectives about what would fit well and not fit well about PCIT with Mexican American families. And we developed a program that was modified based on those families' inputs. And what we found from actually pilot testing that intervention is that it did seem to help. So when we compared, we did a pilot clinical trial comparing GANA to standard PCIT and also to treatment as usual, and found that the largest gains were in the GANA group between pre and post treatment, and that the improvement was significantly greater compared to treatment as usual. It was not significantly different from PCIT, but as you can see, PCIT was sort of intermediate in terms of improvement between GANA and treatment as usual. And those gains were maintained 24 to 36 months post-treatment. So we found this was very encouraging because it suggested that making cultural modifications to treatments was something that, actually could potentially improve outcomes, and that it certainly didn't harm outcomes. And that's always an issue with adaptation is, okay, we can make changes, but are we actually making the program less powerful when we make those changes? So we were encouraged by this to think that making these kinds of cultural modifications could actually really have an impact. And in fact, there's been a number of meta-analyses done at this point looking at culturally adapted treatments across the board, not just for PCIT and not just for behavioral parent training, that really indicate at least moderate effect sizes, moderately larger effect sizes for interventions that have been culturally modified compared to standard interventions. So attention to culture does actually translate into better outcomes for families. But this approach has its limits. So coming up with a specific program that is designed for a particular cultural group can be very helpful, and we see can actually improve outcomes, but it's hard to actually disseminate. And the reason is because, you've got therapists out there as therapists, we're all seeing people from all kinds of different cultural backgrounds, and it would be very difficult for us to learn different versions of each treatment for every single ethnic group that we're having contact with. So it becomes very difficult to disseminate those versions and get uptake on it. It's also potentially difficult for it to be responsive to within group variation. We really did try to attend to that in Ghana. We had some personalized aspects to it that I'm going to kind of expand on in a minute. But you know, by changing the title of an intervention, or by changing the names of the things that we called what we're doing in the intervention, and by adding in various adjuncts to the intervention, we were doing that based on what we learned from Mexican American families. But it's also possible that we have a family come in for whom those adaptations actually are alienating. So for example, one of the things that we learned from Mexican American families was that they preferred not to view the intervention as therapy, which was why we changed the name to Guiando a Niños Activos, because it takes the word therapy out and it focuses more on guiding active children. It's a depathologizing version of the title. But it's possible that we have a Mexican American family come in who absolutely wants therapy and wants to call it therapy and engage with it as therapy. And we would not have that flexibility necessarily to change that sort of aspect of the intervention based on the individual family's needs. So maybe not as responsive to, you know, the individuals that are coming to seek treatment for us. And another issue is that, you know, increasingly our population is multi-ethnic, and we have families that don't have a clear single ethnic group identification. And it may not be possible to have a intervention that's tailored specifically to every culture that's out there. And then finally, culture is changing over time, and if we try to actually, you know, meet the moment with a particular cultural group, we may find that that actually changes and that our intervention becomes quickly outdated. So that specificity can be limiting. And so what we really wanted to propose or examine doing in this most recent work that we're doing is the idea of trying to do personalized interventions. So instead of coming up with an intervention that is made for one specific ethnic group, instead thinking about how can we best take the information that we have about each individual family and use that in an efficient way to actually change the way we're presenting treatments to families to make it work better for those families. And this is a perspective that's being, you know, becoming popular across all of medicine, and in mental health, and also in physical medicine. And NIMH has defined it as basically interventions that are responsive to something about the individual that differentially predicts how he or she will respond to a given treatment. So that means that whatever intervention we choose, we need to think about what do we know about what predicts who this works for and why, and is there any way we can actually change the way we're actually delivering the intervention to make it more likely to work for each individual family or each individual client that we see. So that's kind of led to the current study that I'm going to be talking about in more detail today, which is called Personalizing BPT for Culturally Diverse Families. And our aim in this study was really to try to find ways to maximize the match between what we're calling parent explanatory models and treatment. And I'm going to talk about what I mean by parent explanatory models in more detail in a second. But just to give you an overview, the idea is to come up with a brief, standardized pre-treatment assessment of the cultural characteristics that families may have that have a demonstrated relationship to treatment engagement and outcomes. So what do we know about what predicts how well families are going to engage and benefit from our treatments? And how can we learn what those are before we start treatment with the family? And then to use that information to trigger the deployment of a range of standardized treatment modifications that could potentially maximize the cultural fit for each family. So based on what we know about that family, then what do we actually do to address some of the factors that they may be experiencing that are going to potentially make it more difficult for them to engage in treatment? So to back up for a second, let me talk about parent explanatory models. Because that's really what we're working on here, is we're trying to kind of take into consideration what parent explanatory models our families have when they come into treatment and adjust our presentation to them accordingly. So the definition is of parent explanatory models, or PEMs, I call them, are parents' attitudes, beliefs, and expectations about problem causes, illness course, and treatment. So what are parents thinking as they enter treatment about how they got in that situation in the first place, where their child's problems are coming from, and what they think actually could potentially be helpful to treat those problems. We know that families come in with all kinds of ideas before we ever get started, and sometimes we just kind of dive right into treatment and we don't spend the time trying to figure out where the family's coming from in terms of their perspective on how the problem got started. And we know that the extent to which a person's parent explanatory model fits with the treatment that's offered is going to affect how much alliance they have, or the quality of alliance they have with their therapist, and also how well they do in therapy. So if you come into treatment thinking that your child has a biological problem and your therapist is offering you a parenting skills intervention, you may feel like, wait a minute, how is this addressing what's going on with my child? This isn't going to work. because this isn't really getting to the root cause of my problem. Alternatively, if you have someone who comes in and believes that, you know, their child is actually having a spiritual issue and you offer them medication, they're also going to similarly struggle. So what we're trying to do is figure out, you know, how to increase the match between what we're offering and the way the family is viewing the problem to increase that alliance and to improve outcomes. And so we have developed what we call Person as a method to increase this match between the parents' explanatory models and the treatment that we're offering. Okay, so just to kind of give you an overview of the research that we've conducted, the study itself has 4 phases. The first phase was developing assessment and personalization materials for what we call MyPCIT. And MyPCIT is basically the version of PCIT that we came up with by applying this personalization procedure. The second phase is to train therapists to implement MyPCIT. The third was to pilot MyPCIT with approximately 28 families. We actually got up to 32, excuse me, from 4 different racial ethnic groups to see how it actually works. And then we are currently in phase 4, which is examining the outcomes and trying to figure out whether or not the things that we did increase the match between parent explanatory models and the treatment they were receiving over time. And we're kind of going slow in this phase right now due to the pandemic. I would have thought we'd been farther along, but we got kind of locked out of our labs for about 5 months. So we're just starting to get back on track and get our data cleaned and ready to share. Excuse me, I need to take a pause. Actually, I forgot to write my order down. Okay, sorry. All right, so to start with, the first place that we start in our model of Person is to identify the parent explanatory model dimensions that are actually important to determining whether a family engages and benefits in treatment. And I know that there are many of these PEMs that have yet to be identified. We may not have research demonstrating that some very important factors that families come to treatment with affect their outcomes. But the starting place for us was to try to identify candidates that, first of all, vary across cultures. Second of all, actually have been shown in the literature to predict engagement or outcomes in behavioral parent training, and that we thought could feasibly be addressed through modification. And we came up with 4 areas that kind of met our standards to be identified as PEM targets. And I think these PEM targets, it's worth thinking about, are very general. So if you think about each one of these, perhaps parenting styles might be a little bit more specific to behavioral parent training, but the chances are excellent that each one of these PEMs that we're going to talk about is going to affect engagement across the board in a variety of different kinds of treatments. So your treatment expectations, you know, for example, you have treatment expectations whether you're entering treatment for selective mutism, whether you're entering treatment for oppositional defiant disorder, or whether you're entering treatment for schizophrenia. You're gonna have treatment expectations regardless. And so these things actually really can be, and our hope is that, you know, we're using behavioral parent training and PCIT as a specific example, but that these kinds of PEMs would be present in every kind of treatment and potentially not really even look that different in terms of the factors that might be important across treatment modalities. Okay, so I want to go through each one of these PEMs and talk about why we selected it and why we think it's important to address. And the first one is parent treatment expectations. We know that from actually quite extensive research that ethnic minority families are more likely to have negative outcome expectancies when they come into behavioral parent training, and that those negative outcome expectancies also partially explain poor outcomes and engagement in behavioral parent training. And there really are 3 dimensions to parent treatment expectations that have been demonstrated to have an impact. One is having inaccurate role expectancies. So that would mean coming into treatment not understanding what was going to happen at treatment. So a classic one that we see a lot is parents coming into a program like parent-child interaction therapy, thinking that the therapist will meet alone with their child, and that the parent can just drop the child off and go do something else for an hour and come back and pick up their child post-therapy. So not understanding that they're going to be playing an active role in treatment and are going to be asked to make changes to do practice assignments at home. And so that would be an example of an inaccurate role expectancy that a family might come in with. And of course, when that happens, we find that families drop out. So I had done a qualitative study very early on in my career where we asked families why they dropped out of treatment, and a surprisingly large number of them, I think it was around 40%, basically said that their child hadn't gotten any better. But these are families who dropped out after one treatment session. So their expectancies about what's actually going to happen in treatment may not actually be what the therapist is thinking, which is, hey, we were just getting, some background on you so we can start treatment. They were expecting real change just with one session. And so that clearly is going to put the family at risk for dropping out when that expectancy is not met. The second dimension is expectations of poor outcomes. So if you think the treatment's not going to work, you're probably going to be less likely to engage and benefit from treatment. And then the last one is low parent motivation, which is, you may recognize that a change needs to be made, but you may feel that it is going to be exceedingly difficult and that you're not sure that you can actually do what you're going to be asked to do in treatment. So these are all things that if a family comes in with these kinds of expectations, it'll actually predict poor outcomes for that family. And it's possible that if we know this ahead of time, we may be able to address them. The second parent explanatory model dimension that we're interested in is parent etiological explanations, which is basically what parents think caused their child's problems in the first place. And I've been very fortunate that my co-investigator in this work, Dr. Mei Ye, is the world expert on parent etiological explanations and has done a lot of the seminal research in this area. That has really demonstrated that ethnic minority parents are less likely to endorse biopsychosocial explanations for their child's mental health problems, which means, and what we're offering is a biopsychosocial intervention. So if you don't feel like your child's problem was caused by something biopsychosocial in the first place, you can see where it's going to be harder to engage that family in treatment. And we also know from research that less acculturated parents are less likely to agree with their therapist on what caused their child's problems. And so again, this creates a mismatch between what's being offered and the parent's conceptualization of the problem that can interfere with that engagement. So that's our second dimension that we're interested in, because it's related to lower rates of mental health service use, poor treatment engagement, poor adherence to BPT, and poor treatment outcomes for ethnic minority families. So I think that to think about, we think a lot about in behavioral parent training, families coming in thinking, okay, my child has had a traumatic experience and that's what's causing their problems, or that my child has had maybe has been in foster care and has had a parenting disruption, or my child is got a very difficult temperament, or my child had some biological problem that caused their issue. Or for some of our ethnic minority families, it may be my child is coming to the United States and is now being exposed to a culture that is not my culture, and this culture is teaching them to behave in a way that I don't respect or approve of. So those would be some etiological explanations that we'd want to be aware of. And I would imagine that some of those may overlap with what you would see with selective mutism and some may not. There may be some of those things there, and then also some additional kind of common things that families are coming in terms of their beliefs about how the child developed the symptom in the first place, that is going to impact how well they receive what you then offer them as a treatment. The third parent explanatory model dimension is parenting goals and practices. And so basically we know that when parents come in to treatment, they have really strong beliefs that are very culturally determined or culturally influenced about what kinds of parenting practices make sense and what kind of parenting goals they have for their child. What are they actually shooting for in terms of raising this child to function within the culture that they're ultimately raising the child to be a part of. And that if we present treatment, or if we present the treatment as parenting practices that are inconsistent with those goals and culturally influenced practices, we're going to meet with resistance, because families are going to be like, wait a minute, this is kind of the fundamental thing I do, is try to convey my values and my culture to the next generation through my child, and you're telling me to do it this different way. So being aware of the ways in which parenting goals and practices do or do not fit with PCIT or any intervention that we're using is also a really important place to start. And we know that Latinx, African, and Asian American parents are tend to be higher on authoritarian parenting than non-Hispanic whites. And we also know that authoritarian parenting relates to poor retention and outcomes in behavioral parent training. I think it's really important to not look at that judgmentally. I think that Latinx, African, and Asian American parents have lots of really good reason to adopt a more authoritarian stance in their parenting, and they may, in certain situations, not have much of a choice based on the pressures that are placed on those families. But we do know that when we come in with parenting interventions that are going to be consistent with that, it's going to feel like risky and scary to them. It's going to feel like making a wrong decision for their child. and we're going to need to spend extra time kind of trying to figure out what would actually make this work for them and how to explain things or what we're trying to do in a way that makes sense with what they're trying to achieve for their child. There's less sort of empirical support for the idea that permissive parents also struggle in BPT, but our expert advice and our own personal experience really told us that permissive parents, we usually see authoritarian parents really struggle during CDI, the first part of parent-child interaction therapy, in which we're really emphasizing warmth and praise and playing, but that permissive parents really struggle in behavioral parent training with things like ignoring and also with timeout. So even though we didn't really have as great of an empirical excuse to include it, we also hypothesized that permissive parenting would be a risk factor for families to do more poorly in PCIT than if obviously they came in with authoritative parenting. Okay. The last parent explanatory model dimension that we were interested in is family support for treatment. And so family support for treatment is basically just how much do family members that are not the parent bringing the child in for treatment support the idea of this child getting this particular intervention. And we know that ethnic minority families on average report more collectivism, and that collectivism can really be very helpful to families in terms of providing a source of support, but also can amplify the effect of family members' opinions. So if you're a member of a collectivistic culture, your mother's opinion may be more important to you about how you, whether or not you bring your child to mental health treatment than it would if you were in a more individualistic culture. Your aunt, your uncle, your cousin, your farther out family members, their opinions may actually have more of an impact on how you decide to handle your child's problems than they would if you were in a less collectivistic culture. And so we find that when familism goes together with low support for treatment, that is a predictor of premature termination for families and also lower ratings of treatment acceptability on the part of the family. And so what we would like to do is to actually be attentive to what family members are and are not supportive of treatment as families enter treatment, so that we can be aware of and address any lack of support that exists there. And again, some early studies that I had done really showed that almost close to half of the families that enter treatment have at least one family member, this was among Mexican American families, have at least one family member who did not think that they should be taking their child for treatment. And that can be very difficult because we're asking the parents, of course, to go home and do things in front of their family members who are not supporting that treatment. And we know that that's likely to undermine their success. Okay, so those are the four dimensions. And I want to talk a little bit about what we're doing with those dimensions and sort of the process of personalization. So the process has sort of 3 steps in it. First of all, we are starting with assessment. So we assembled measures of these PEMs that have been associated with poor engagement and outcomes in behavioral parent training. We then established cut scores and programmed we programmed this into a tablet computer so that the parents can take the questionnaires, and then the questionnaires will be automatically scored, and then a report will be generated for the therapist that indicates what the family's standing were on those measures, but also gives the therapist some suggestions and some materials that they can use to personalize the program for those families. And so we, in this development process, developed about 35 to 40 personalized materials that we felt would be helpful to therapists to actually adapt the treatment to fit better with a parent's particular perspective. And so part of what goes into that report is telling the therapist, okay, here's how the family scored, and here are these personalization materials that you could potentially use to help this particular family. So what the family ends up getting is every family is different, and depending on what they actually tell us in the assessment, we give the therapist a different set of tools to use with that family that we think potentially could be helpful. So let me kind of go through a sample case to show you kind of what that might look like. So this is a amalgamation of many cases that we've had, and it's a little boy named Joaquin, who's a 4-year-old Mexican American boy that was brought in by his bio mom, whose name is Pilar. The parents immigrated from Mexico as teens, and they are Spanish speaking. The mom has less than a high school education, and the child is the youngest of 6 siblings. So this is a family where mom is working a lot. She's got a lot going on with lots of family members, and so her mother is involved in childcare. So she's taking care of the kids, helping mom out a lot during the day. Their pre-treatment ECB, which is an indicator of child behavior problems, was 183. And also kind of their main presenting problem was that this was a child that was in Head Start. Head Start was having lots of trouble with non-compliance for the child. The child was having lots of frequent and severe tantrums at school. The mom reported the same thing when she was with him as well. And that he was showing some aggression in preschool and towards his siblings. So a very typical case that we would see for parent-child interaction therapy. And this is kind of what we would have. This is the report that would be generated. So we would have the family come in, fill in that questionnaire, set of questionnaires in the tablet, and it would generate a report that would look something like this. Basically, on one side, this is not the whole report because this report's too long to fit on a slide, but just to give you a sense, we have a listing of kind of each of the major phases of PCIT, starting with CDI teach, CDI coach, PDI teach, and then throughout therapy. And then we have a list of materials that we are suggesting the therapist might use to better engage this family. And then the second page goes into more detailed report findings. So if this family, for example, had some inaccurate role expectations. They believe that only their child would be seen in treatment, and they did not believe that they would have to practice the skills. So they're going to be a little surprised when they get into PCIT and find out that that's not actually the case. They also reported some concerns that their child won't want to go, that their child's going to be labeled or teased for attending the program, or that they're going to be experiencing challenges around privacy and confidentiality. So that would be an example of some of the areas that, okay, as a therapist, you want to know about that. And then on the other side of this chart, we also have some tools that we have developed that could directly address those issues. And then there's going to be some areas where nothing needs to be done. So they don't have any, this parent has high expectations for treatment outcome. So we don't really have to spend much time worrying about that. We need to spend more time worrying about the things that might actually predict them dropping out from treatment. Okay, sorry, this was, so just a little bit more detail because that was only part of the report. We already talked a little bit about the fact that they had low expectation for treatment success and inaccurate role expectations, but good motivation for treatment. In terms of etiological explanations, they felt that their child, Joaquin's problems, was caused by ADHD, and that was the reason why he was struggling in school. The mom's parenting style was permissive, and when she was asked about the techniques specific to PCIT, she reported that she felt it would be she wasn't interested in learning about ignoring, using timeout, and praise. Those were areas that she felt like she wasn't were not going to be particularly helpful for her. And then in addition to that, she also reported to us that grandma did not support this child coming into treatment because she felt like he didn't have a mental health problem, and therefore why is he going to seek therapy? Okay, so that's kind of the starting point of treatment. And I want to share with you just some examples of some of the materials that we use to actually modify or to actually personalize the treatment, some things that the therapist could actually use with the family. And there's more than we could fit in, this short example, but just to highlight a few examples. So, excuse me, first of all, we know that this parent had some inaccurate treatment expectations. So they were actually enthusiastic and open, thinking treatment would work, but they didn't really understand what was going to happen to them in treatment. So we have this handout that we call What to Expect from PCIT, which basically just gives very basic information about what PCIT is, how does it look like, what does it look like, how does the coaching work, what are you going to be asked to do, and it tells the parent about the importance of practice kind of from the get-go, with some research support showing that parents who practice more at home see greater improvement in their child's behavior. So this is just a tool that a parent or a therapist can use to orient the parent who does not know what to expect from PCIT. We also share information with them about PCIT and how PCIT can help their family. So it not only teaches the parent about the goals for treatment, but it also gives them some information about how likely it is that their child is going to show improvement, showing 8 out of 10 children reach healthy behavior levels after the program, and showing them the extent to which parents see changes in their child's behavior, but also shows them kind of the timeline for that. So this last little chart on the bottom here shows kind of the number of PCIT classes with the level of behavior problems, and shows them that most parents will see some improvements immediately, but really more significant improvements by the 7th class, and healthy behavior problem levels by the 15th. So it gives them a sense of kind of when that's going to actually occur, because we found definitely with families that their timeline is not the same as our timeline. They're definitely expecting much more rapid improvement than we can typically offer, but knowing when they should start to see changes it can be very helpful. So the second PEM that the family had scored on was etiological explanations, which was, and they had said that they felt that their child's problems was caused by ADHD. So with each parent, unless their explanation is parenting, which fits perfectly with the PCIT behavior model or intervention model, we feel like there's a possibility that parents will say, well, why are you giving me this PCIT for my child's ADHD? Like, isn't ADHD a biological problem? Like, how are you going to actually make a change or a difference in my child's life if you are giving them a parent-child interaction therapy intervention? So we have developed individual handouts for each kind of etiological explanation that isn't the obvious one of parenting, that kind of goes through and summarizes the research that has been done with children with that particular diagnostic problem, that kind of breaks down the rationale for why it works with that particular kind of child, and also any kind of official recommendations from, say, the American Academy of Pediatrics or other places that support the use of PCIT for that particular problem. So our idea is to help parents feel like, oh yeah, okay, this is an intervention for ADHD. This has been researched. People have done this before. Oh, I get how this might work, and kind of go through that application of this intervention to their child's specific problem cause that the parent feels is operable. Okay. The third PEM that we would address is parenting styles. And so we know parents come in oftentimes with either authoritarian or permissive parenting backgrounds, and that can really impact the way they receive our message. And we might want to deliver things differently depending on whether the parent is actually more permissive or more authoritarian. And so this handout basically goes through talking about that warmth and discipline, the balance between warmth and discipline, but from the perspective of a parent who may actually be more permissive. So kind of pointing out that, while being permissive can feel good in the short term, that it can often lead to lots of yelling, which can actually interfere with the relationship between parents and children. And so you're going to be improving your relationship with your child if you actually more consistently enforce limits. If that's an example. So there's several kind of points in here. And this is probably one of the things we've got some complaints about, is that the handouts are a little bit wordy, and we're probably going to be working on trying to, create kind of a therapist guide version and a version that goes to the parents that's a little less wordy. So that's kind of one of the things that we're refining. This is an example again of, remember, that the family was not interested in ignoring, which is not an uncommon problem in PCIT, because we train parents to ignore minor misbehavior, and that many parents feel like just letting it go and not responding. And so we have this little handout called The Secret Superpower of Ignoring that basically acknowledges that, saying it can feel like, ignoring can feel like you're letting kids get away with something, but your ignoring is actually a really powerful tool, because it's your parental attention, which is really what kids thrive on. And because you have control over that attention, you have like a superpower that can, affect your child's behavior, and sort of kind of going through more detail about why ignoring is not, in fact, doing nothing. Okay. Another thing that we do with a lot of families is we generate personalized label praises. So families whose parenting approach don't feel that it fits very well with PCIT, we have developed something what we call personalized label praises. So we ask families at the beginning of treatment their most important values for their child. And then we generate a list of label praises that specifically fit with the values that those parents endorse. So a very common value was child having self-control. And this is here is a list of things that a parent could potentially praise that might actually reinforce their child having self-control. So we do that for whatever value the parent presents. Okay, I'm going to kind of go through a little faster because we're short on time. And just say that for family support for treatment, when we've identified a family member who's important to the parent and not supportive of treatment, we have some very tailored handouts for those individuals to help them understand their importance in this model, and to try to present the model in a way that we feel will be consistent with what the family member would like to see. And then we also provide them with other forms of media, videos, newspaper articles, and other materials that families can read on their own to learn more about the treatment program and why we're doing what we're doing. And again, we do that only with a lot of input from the parent themselves. So if the parent doesn't feel that that would be helpful, or if they feel like something else would be more helpful, we let them kind of guide us in terms of what they think would actually help engage this family member. Okay, so I just have a couple minutes to go through the data, and so I'm going to try to do this kind of quickly. But what we have so far, so we're kind of in this phase 4, as I said, where we have piloted my PCIT with about 32 families from a range of different ethnic groups at mostly at Rady Children's Hospital in San Diego, but also a few families were seen in our lab at the University of San Diego. Mostly by a Children's Hospital staff therapist, but also some student interns and one faculty therapist. We had, excuse me, we were shooting to get a very multi-ethnic sample, and I believe that we succeeded. We were shooting to get representation from 4 different ethnic groups: Latino, non-Hispanic, white, African American, Asian American, and we also had a substantial number of families that were multi-ethnic as well. Typical demographics for a PCIT sample: kids average age of 4.66 years, a monthly income of about $6,500, pre-treatment ECFI well into the clinical range, and a sample that was tilted towards males, but not nearly as much, honestly, as some of my other samples of PCIT. So it was actually kind of more gender balanced than we typically get, but still more boys than girls. And what we've kind of found so far is that, first of all, a lot of the materials that, or a lot of the assessment identified a lot of risk factors in the families that could prevent or interfere with engagement and prevent them from benefiting from treatment. And so I'm going to kind of leave interdependence out now because I didn't really introduce that as much as going through it. But beliefs about child's problems being incompatible with the therapy being offered was present in about 80% of the families. So that's important to know. A parenting style that was inconsistent with what we were going to teach them in PCIT, either authoritarian or permissive, was present in close to 80% of the families as well. About 75% of the families reported that there was at least one behavioral parent training technique that they were not excited to learn about. So they were already feeling negatively before we even started. About 50% had inaccurate expectations about what was going to happen in treatment. About 25% reported low motivation, and a little bit less than 25% reported having a family member who did not support them taking their child for treatment. So to kind of give you a little bit more detail, about 50% of the primary caregivers endorse at least one inaccurate treatment expectation, such as only my child will be seen in treatment, my child will be mostly talking about his or her feelings in therapy rather than learning how to behave differently, and that I will not have to practice skills out of the session for the child to improve. So you can see that's kind of a setup for a difficult time in PCIT. Only about 3% endorse low expectations for treatment, but about 25% endorse having low parent motivation. In terms of etiological explanations, the most common was personality or temperament, but also a significant number reported ADHD, a biological, genetic, or medical issue, trauma, and parenting was only about 9%. In terms of parenting style, 81% of parents were elevated on either authoritarian or permissive styles, more permissive than authoritarian. And then we have that 3% that's both authoritarian and permissive that are going to really struggle. And about 94% scored high on interdependence, meaning that family closeness was very important to them. About 75% of the sample expressed some kind of discomfort with at least one of the BPT techniques. The most common was ignoring, which should come as a surprise to no one who's ever done PCIT. But there was also some resistance to reducing criticism, to timeout, to playing, and to praising. In terms of the values for personalized that drove our personalized label praises, the most common values selected by parents were having self-control, being kind and considerate, thankful and appreciative, empathic and compassionate, honest, obedient, and polite. So those are good ones to keep in mind when you're coaching families. And then, as I reported before, 22% reported a family member that didn't support treatment. About 50% of those family members were fathers, and the other 50% were grandparents. And the most common reason was that either the family member was unsure about what the program entailed, that they thought the child didn't really need help, or that they thought the child would be labeled or teased. And that families were most open to having, when we're in terms of requesting an intervention, for the therapist to discuss ways to engage the family member with the client, him or herself, to share video links so the family member could learn more about PCIT, or to provide the family member with a newspaper article about PCIT. And just really quickly, in terms of what we found so far with our data, we are still very much in the data analysis and even in the data cleaning phase. So that's why every slide is marked preliminary data. because things can change. And so I want people to take all of this, you know, I don't think it's going to change very much, but, you know, we're still in the process of getting our data 100% clean. So we can't, this isn't our definitive results, but we're finding pre to post change on the ECB that is very robust and similar to what we see in other trials of PCIT with this personalized version. And we're also seeing the same kind of pre to post change on the DPIC. So a highly statistically significant increase in do skills and decrease in don't skills on the part of the parents in PCIT. And then also when we break it down by child-led play, parent-led play, and cleanup, we're seeing the same patterns. Significant increases in do skills, significant decreases in don't skills for parenting. So our outcomes are looking very nice with this personalized version of PCIT so far. I think I need to go ahead and stop here. We had some feedback from the therapists of what they liked and didn't like, but I think I need to go to questions so we have some time. And really what our next steps are is to determine whether we can differentiate my PCIT from standardized PCIT, compare our outcomes to other clinical trials, and see whether what we're doing with our personalization actually changes and increases that match between parent explanatory models and the treatment over time. And we hope ultimately to have the ability to do a full-scale RCT to see whether personalized PCIT can outperform treatment as usual and possibly standard PCIT as well. And I want to give lots of thank yous to my lab, of course, to my co-investigator, Dr. Maye, has been, you know, such an important person in my life, and also an equal partner in this work. And then also the people who have been the students in my lab, but also Sheila Iberg, who developed PCIT in the first place and provided me training on it and has been supportive every step of the way. Our consultants on the cultural aspects of our intervention, and the community partners that we have been working with to deliver the intervention, and also, of course, our funding agency, NIMH, and my institution, University of San Diego.
Kristen, thank you for that New York-paced, intense overview.
I have to go faster because
can you exit the slideshow?
Okay, so yes, let me do that.
So while you're doing that.
So how do I unshare my screen? Maybe I should do that.
Actually, you can leave it there. In fact, if you can go back to the frequency of triggered material slide right near the end, that would be great.
Oh, okay.
And while you're doing that, so I'm just going to remind everybody the context of this invite and this presentation. So with our increased awareness of anti-racism movements, the increased awareness of the need to correct the systemic racism in our approaches, the board of SMA is working hard to take a good look within. We're a very white board, and we know we have work to do. And one of the things we wanted to do is begin to think about the treatments we're offering and how they map onto or match with the many families we're reaching and the many families we're not reaching for some of the reasons that Dr. McCabe talked about. So there are a lot of great questions. I'm going to get to some of them. When you refer to interdependence, can you just go over quickly again what it is you meant by that?
Yes, I kind of glossed over that. So basically, interdependence is the idea that a family, families from collectivistic cultures are more likely to value family closeness, and that's something that we can really emphasize in PCIT for some families, is the ability to kind of bring other family members kind of into who maybe aren't even present. So an example of that could be, and praising a child, saying, "Oh, grandma would love the way you used, such a respectful tone," or grandma would love the way you put the trains together, or kind of bringing in other family members into the room in terms of the intervention beyond just the parent.
What's fascinating about that for this community of people who work with selectively mute kids is that the impairment itself, almost by definition, involves extended family. Mm-hmm. So we have this very interesting kind of overlay of not only trying to make sure that the extended family is providing the necessary support, but actually using some of the same skills, and the parents become the agents of change in this work as well. So you can imagine that the ripple effect, if you will, of understanding the explanatory models for both the parent and the extended family. So it resonates for those of us in this community quite a bit.
Okay,
so one of our folks was asking if you were familiar with the work of, let's see, I want to get this right. Nancy Boyd Franklin and her work on authoritarian parenting style as a protective factor for African American children, and again, how you try to interface that cultural information with behavioral parent training.
Yes, that's such a good question, because I mean, I think it's really important to note that every culture has developed it has developed parenting strategies that promote success for the children that they're raising in that particular cultural context. And we know that that cultural context matters, and the kinds of things that, you know, being authoritarian in one culture may not have the same meaning or the same effect on a child as being authoritarian in another culture. And it may actually be, you know, somewhat adaptive in certain cultures where, you know, really maybe the margin for error is not as great, because you have a child who is going to be subject to discrimination and possibly perceived differently by authority figures. And so maybe that, you know, defying authority is something that is not as acceptable or safe for that child as it would be for a child from the majority group. So I think we need to recognize that, absolutely. I would also say, though, that there's many things about PCIT and the way in which we help parents actually increase their warmth that doesn't seem to be harmful for children. So, and I think there's definitely, I think a lot of the research on parenting with African American families that's focused on authoritarianism focuses more on the beneficial effect of the limit setting and less on the part of authoritarianism that really PCIT kind of, you know, is trying to change, which is a lack of warmth. So I've yet to see any study that demonstrates that any child is harmed by the expression of warmth. And I think that what we see from the outcome studies with families across cultures is that we do see in PCIT improvements in child's behavior problems and improvement in that relationship. And so I have every reason to expect that this is an intervention that it actually can be helpful for parents, even in those contexts. But I completely understand the point that, you know, it isn't the same. The parenting behaviors are culturally contextualized, and they mean different things in different settings.
So what's interesting about both PCIT for kids with disruptive behavior and PCIT for selective mutism or other behavioral parent trainings for selective mutism is that we have a marketing problem, which is that the start of the therapy is the exact opposite of limit setting, right? The start of both therapies is child-directed interactions. So we have a bit of a marketing problem, which is where I appreciate and I've already used your kind of approach in my clinical work. The reason I asked you to pull up this slide is that I think for the clinicians out there, which is the vast majority of people attending today, and you know how webinars and talks go. People want to know, can you send me your materials? How can I use it starting with my 3 o'clock patient this afternoon? And it occurred to me that this slide is the starting point, because even if you don't have your fancy tablets with the PEMs questionnaires that are not ready for prime time delivery, all of us could begin to explore with our families the interdependence issues. What are your beliefs about the cause of the problems? How acceptable are these techniques going to be for you? What are your expectations about our roles? And so even having the discussions just based on this slide alone, I think gives people a starting point for this kind of integration.
Yes, and I think, yeah, that's exactly right. And we're hoping, the whole hope of this is not to have this be something that only is applied to PCIT. I mean, we haven't demonstrated that yet because we're still kind of getting started with the first thing. But I mean, I love that the things that we identified are general enough that you can envision how this could be translated to other interventions. I mean, everyone has expectations. It doesn't matter what kind of treatment you're entering. Right. Everybody has family members that may be or may or not be supportive.
Any thoughts, hypotheses, or data about the match and mismatch of race and ethnicity for your treating clinicians and the consumers of the services?
Yes, I mean, I think ethnic match is, been demonstrated. And actually, Dr. Ye, my co-investigator, was one of the kind of pioneers in looking at ethnic match in treatment for young children, and it does seem to be important. But I think what we have kind of realized as we learn more about cultural competence, that really the cognitive match between the therapist and client is equally, if not more important. So actually having a shared understanding of the problem and having a shared understanding of the causes of that problem and what would help that problem seems to be more important than ethnic match in and of itself, and may actually partially explain why ethnic match even matters. And so that's the reason why we're kind of taking our work in this direction, as opposed to focusing on ethnic matching. And then in addition to that, ethnic matching has always just got a sheer practical issue with it. At the end of the day, our main thing we're looking for in a treating clinician is not necessarily that they're matched with our ethnicity, and we may have to take lots of other factors into consideration when we get a clinician that have nothing to do with their ethnicity. So that means that we as clinicians are working across cultures all the time. Correct me if I'm wrong. We're pretty much always working with people who are not going to be in our ethnic group. And that's true not just for European American clinicians, but it's true for Asian American clinicians, it's true for Latinx clinicians, and it's true for African American clinicians. You don't usually just work within one ethnic group. And so the idea that you're going to always have an ethnic match is not practical, and even if it might be desirable. And we all need tools to figure out how to work better with people who are different than ourselves, in addition to just besides just counting on like, okay, we could just match the clinicians and clients' ethnicity.
And I would say for those who haven't crossed over and just started asking families about their concerns about match or mismatch, that it's a conversation that usually ends up where folks feel supported and validated. And I think we're all trying to figure out how to do more and more and better with that, but it starts with open conversation, to be sure. I want to try and keep up with all these great comments. Dr. McCabe, are you comfortable sharing your slide deck with participants?
Yes.
Okay, we'll work with you to make those available to people. I figured you would say yes. Scrolling through. So, fabulous presentation. Based on this research, what are your top 3 tips for PCIT trainers conducting basic PCIT training with new trainees? And this comes from your friend and mine and our mentor in common, Cheryl McNeil.
Okay. Well, top 3. That's tough. I would say that it's kind of the basic framework, conveying that to trainees is really important. Just I think one of the things that's really tough for trainees is when they first start, there's so much to keep straight. They're learning the DPICs, they're learning all these technical rules, and it's hard to kind of step out and look at that bigger picture of what are parents coming to this intervention with, and how can I adjust, what I'm doing to actually meet them where they are. So I would say probably the number one thing would be to kind of just be aware of what are the predictors of poor engagement and dropout in PCIT, and how can I actually build into my intake assessment some attention to those features so that I find out about them before we start, as opposed to on session 5 when I realize that grandma is taking the child, out of timeout, and we're already having the problem, and it's kind of, down the road to actually deal with it. So I think kind of getting people into the habit of kind of paying attention to these issues from the beginning would be one of my big ticket items. And then also just sort of building up a repertoire of different ways of explaining the PCIT concepts for different kinds of parents. And Cheryl, you've been great at doing this yourself and promoting materials that actually help people think about, okay, how do you talk about timeout with an authoritarian parent? How do you talk about timeout with a permissive parent? How do you talk about ignoring with an authoritarian parent? How do you talk about ignoring with a permissive parent? It's different, and you have to kind of be flexible in terms of how you present that rationale depending on what the parents' beliefs are that are coming with it. And then the third thing I would really ask trainees to attend to is really being clear on what the parents' goals and values are. And I think that's, an experienced trainer, experienced PCIT clinician does this somewhat automatically, but for new people who are really struggling to learn the techniques, kind of making sure that you always have written down in front of you, what are my parents' 3 biggest goals? So that when you're coaching CDI, for example, if you have a parent whose biggest goal is their child having, frustration tolerance, that you're taking every praise that you can give around a behavior you're choosing to emphasize the extent to which that's promoting frustration tolerance. Or if you have a parent who respect for elders is extremely important, that you are praising that child for respecting elders in any context that you could possibly come up with in a play situation, and trying to remember that and keep that going throughout the entire treatment. So those would be my top 3.
I hope I did justice to the many great questions and comments that we got. I knew going into this that we would run out of time. It's the nature of the beast. Kristen, thank you so much for your expertise and your generosity of your time to present this again to us. And to our selective mutism community, I know that this would be a start of a conversation for us and a way to think about approaching our work. I knew it would not be the be-all and end-all. So the task is really on us to extrapolate this to our clinical work and to be on the lookout for more of Dr. McCabe and her team's published research, which I will be sure to bring to the SM community. But we'll have to sign off for now. Kristen, thank you again. And again, we'll be sending you all a link coming soon.